Well, good morning, good evening, good afternoon, everyone, wherever you are in the world. My name is Mick, founder of the ACL Hub, and I've got the absolute joy and pleasure of talking shop again with my good friend Lenny Macrina. It's Lenny Macrina. I'll just
Macrina,
say,
you nailed it. You nailed it.
nailed it, Lenny. Welcome, welcome. Good to chat again. We somehow
Yeah,
managed to find each other online from time to time and talk shop on ACL. So thanks for joining me
I,
again.
I love it. You push me. I love reading your stuff, and it keeps me fresh and engaged, and I love it. So I'm just glad you
Likewise.
invited me on, and ready to talk a little ACL rehab.
Yeah. Oh, the feeling's mutual, mate. What you guys are doing at Champion is nothing short of exceptional. Like you guys are setting the standards in the US and arguably across the world with your, high level management. And I certainly watch what you guys do and try to emulate myself. So it's just nice time to be alive, right? We got great clinicians sharing their tips and tricks of the trade and helping the world become a better place, one ACL at a time.
Absolutely. All we want to
Yeah.
do is help our patients to get better and as quickly and safely as possible. So yeah, let's chat.
Yeah. Yeah, that's cool. Well, for those that don't know, I've got Lenny. I got a bit of a weird and wonderful audience of both patients and clinicians, mixed bag of people across the world and also locally here in Australia. So, for those that may not have come across you or your name before, can you just give people just a brief bio of who you are and what you like to do?
Yeah, I am a physical therapist in Boston, Massachusetts, here in the great old US of A. I've been practicing PT since 2003, so I guess this is my 22nd ish year of doing this. Grew up in Boston, but moved to Birmingham, Alabama, and worked with Dr. Andrews and Kevin Wilk and Mike Reinold, and just kind of grew a passion for sports PT. Published a bunch of papers and done speaking engagements on various topics. And my life has kind of been baseball and related, and it still is. And then this ACL thing, which I've treated a bunch when I was down there, but since I've moved back to Boston, I've really gotten relationships with some of the surgeons in the area, and they trust what we do. And so
Mm.
my life has turned into baseball or ACL. My schedule is, it's a little of both, and so we're always
Yeah.
trying to figure out the best treatment strategies for our ACL patients. And chatting with you is always a pleasure. So yeah.
Yeah, nice. You got definitely a mixed bag there. You wouldn't see too many
Yeah.
ACLs in the baseball population, though, would you?
No, no, but I do have one right now, and we'll probably get to him at some point once we start talking
Yeah,
about graph types. So I'm
yeah,
gonna leave it at that for now.
yeah. Fair enough. And the ones that you do see, they're just coming from the local orthopedic networks that you've got there, or does Champion kind of they're well known in Boston and the States. Are they kind of like a center for elite athletes to go to for that initial care, or is it just you're getting local athletes from around the area, both high school,
Yeah,
college, whatever? Yep.
mainly local. We do have some people that will get in touch with us through telehealth or Zoom or whatever. But mainly local high school, college kids. And if they're a pro athlete and happen to live in the Boston area, they somehow
Yep.
will find us at some point. But mainly it could be early stage, it can be late stage. In Massachusetts, we can see patients without a doctor's prescription and all that. So we're a referral source for surgeons. If somebody comes in with a suspected ACL, I'm sending people out to
Yep.
surgeons as well. So it works in both directions too, which is
Yeah.
great.
Yeah, that's great. Is that unique to
Yeah.
the states? Is it? Yeah. Okay. Yep.
Yeah, the states are crazy. We have 50
Yeah. Yeah.
states, and so there's
Yeah.
50 different laws of what
Yeah.
patient
Crazy.
care can look like. And
Yeah.
so Massachusetts, fortunately, has a very progressive view on patients accessing physical therapy,
Yeah.
in direct access. But where I used to work in Alabama, they had to go through a surgeon, and they still do. I think you can
Yeah.
see patients for like so many visits in 30 days, but not in Massachusetts. I can see people,
Yeah.
as much as I want, and it works really well that way.
Yeah, that sounds pretty similar to what we see in Australia. The kind of
Yeah,
standard is anyone could sort of turn up to our doorstep with any type of injury. They don't need a doctor's
yeah,
referral or a surgeon's referral. They could
correct.
come and get that primary healthcare. then conversely, obviously, if we're suspicious of an ACL or something that needs surgical intervention, it's like, okay, go see your GP. The GP will need to refer you to the specialist. And that way you're already starting a really nice conversation and a
Yep.
good collaborative
Yeah.
approach. So yeah, no,
Absolutely. Yep.
we've got the same system. So it's good that we're kind of
Yep.
on the same
Yep.
page, which is cool.
Yep.
But yeah, it's crazy, like knowing a little bit about the states and how every state is just almost like disconnected to the fellow states around them. So it must be a
Right.
hard place time to work. Before we dive into it, do you have a particular, and I ask this of all my guests, is there a particular kind of philosophy that you kind of align your ACL work with? I know it's probably a very broad question, but like, do you have like
Yeah.
a simple, yet effective approach, or do you lean into, functional exercise, or like, do you lean, what's your kind of grounding in your
Yeah.
approach to physio in ACLs?
I think just my work in writing papers and speaking, my mind breaks it down into different phases. And
Mm,
so I see each phase as like a milestone. So like the first 6 weeks is that critical, calm the knee down, get the homeostasis that Scott Dye talks about. Get motion, get the basics under control, and then after about 6 weeks, and you plus or minus a week or two or three if it's a meniscus repair, or different surgeons have different precautions. So you're playing the game, but you have a goal, and so you go simple. Like don't try to
mm.
do too much too quickly early on, because that can you're not really gonna make too many gains on the back end. You're only gonna make things go a little slower, in my opinion, if you try to go too
Yep.
fast. But if you get things to calm down, and then by that 6-8 weeks, it's the strength training phase, and from 8 weeks and beyond, you kind of turn into a strength and conditioning specialist. But you're still monitoring stuff, make sure they're not losing motion or gaining swelling. And then by 3 or 4 months, it's now strength and conditioning, and it really truly is like, all right, when are we going to start running? We're testing. What we're making executive decisions after that. But I really break it down into different phases and try to tell my students, don't try to go too fast. We have a bunch of students at Champion that we're always educating and helping them along in their journey to be a better PT,
Yeah.
and to be a new grad PT or early career professional. So I really like to break it down into different phases, and that kind of works well in my head.
Yeah, no, I agree, and that's it's a similar theme we're kind of hearing from some other people too. Like arguably we're looking at least a 9 to 12 month rehab process
Yeah.
before they play their first game, and it's for a patient or even a young clinician to sort of look at that and go, holy crap, like where do I start? How do I kind of build, like, to break it down into small chunks for
Yeah.
everyone involved? I think is a really simple and really highly effective way of mapping out. No, that's good. It's good to
And that's
hear.
not to say that I'm time based. I mean, rehab is time based.
Mm,
My return to sport could be, it could be 8 months, it could be 15 months. The
yeah,
time based thing is one small piece. There's so many big things that contribute to that, but the time based thing is a generalization
yeah,
for people to kind of handle that rehab.
yeah, absolutely. It's an interesting little segue because I think there's been a recent paper that's challenged the 9 month figure. If you had a chance to get your eyes around that by Rula Kotsufaki and Enda King and the Aspetar group,
Yeah.
what's your kind of it's kind of like the pendulum swinging back around again,
It's so
like
funny.
to this not focusing so much on time, and now we're letting criteria drive what we
Right.
do. We go back 20 years ago, it was like, let's try to get someone back between 6 to 9, 12 months as oil time based, and it's like, no, hold on,
Yeah.
let's do criteria. It's starting to nudge, and that group in particular have got a couple of really big volume research articles with big volumes of patients and athletes who are saying,
Right.
the second ACL injury risk isn't necessarily dictated by waiting 9 months. It's largely dictated by, passing the criteria. What's your thoughts and feelings there, and what's your kind of approach?
It is funny to see everything kind of shifting around in the
Mm,
pendulum, and it does affect me a little. But I think I've always been. My mind is science. Like, I just think in a scientist kind of way. So I
mm,
can't make a decision unless I test and then retest. And so I
yep,
just need to see numbers in front of me. And yeah, I'm taking into account the sport they're playing. A hockey player playing on ice, I'm going to probably be a little bit more aggressive in letting them go
yep,
back if
yep,
there's a gray area versus a high school female soccer player. I need
yep,
to see like good data that they are ready to go back,
yep,
especially if it's a revision surgery or something. And
yep,
so It is a gray area, but time based. I got two kids right now. I probably could have sent them back to their sport at 7 months out of surgery. They
Yep.
crushed it from the beginning. You know what I
Yep.
mean? And I bought time and I kind of held on to them a little because they're high school kids. One's about to go to play Ivy League lacrosse. So he had the summer to train. Why are we going to be too
Yeah.
crazy? But the time based thing, 9 months, does it have to be 9 months? No. Does some research say it's better off? Yeah. But usually most people are going to be 8 to 12 months, something like that. I got people back at 4 months back in the day. It was scary. This kid with high school kid got back at 4 months out of surgery. 6 months was always like all right, you're cleared. And you're like, oh, okay. I think that's before we really kind of knew as much as we know now.
Yeah.
And now we've kind of slowed things down, and our re-tear rates are about the same, right? Like we're still seeing a ton of people still getting hurt again. So we're missing something.
Yes, we are missing something. We still haven't figured that out. Do you have a gut feel? Do you have a gut feel on what that may be, like neurocog?
I don't know. I don't know if it's the proprioception thing, if it's you tear a ligament that seems to communicate with the brain, and so maybe it is a neurocog thing. I know Tim Hewitt talks about 2 years return to sport. I don't know how realistic that is, but the first 2 years after returning to sport is their go time to re-tear. So I think it's a combo of stuff. Obviously, it's not one thing, but I think us PTs, especially here in the States, are very I don't want to say bad. We're not good at the end stage rehab, and we're limited by insurance and what people value. It's all about getting the kid back to sport, but it's not about the efforts to get them back to sport in a progressive way that involves strength and conditioning and good testing. So I think if re-tear rates are 20-25%, so to speak, hopefully my re-tear rates are 5 or 10%, because we can spend more time with the kids and we have good testing, or better testing that seems to be more appropriate. So, you can make blanket statements, but I think individual clinicians are going to have different, re-tear rates, so to speak, if that's, one thing we look at.
Yeah, great. And I think it's funny you sort of say that, because we probably say the same thing and we feel the same way here in Australia. I think physios here in Australia are great early to middle stages. And once again, we get limited by space and facilities, and we probably aren't the best late stage rehabbers, but I think we're starting to get a better collaborative approach with exercise physiologists, strength and conditioning coaches, and working much better together to drive that late stage to get them back in timely fashions. But
it's part of the team, right? Like you have a surgeon, you have the physio or PT, and then you have the rehab people, but the PT can stay involved, like do the testing. That's what we do at Champion. We have strength and conditioning coaches that the patients end up going to about 4 months out of surgery, 5 months out of surgery, depending on the patient. They do strength and conditioning until they're ready to go back to their sport. But I'm involved in monitoring swelling, monitoring their motion, monitoring testing that we do as PTs, and our strength coaches are also doing it. So I think having a collaborative approach is going to be critical for for better results, right?
No, great. And I think that's also too, for the young clinicians listening to this, is that you don't have to try and do it all. And I think that's probably where I think a lot of young clinicians get tripped up, because they're trying to be the physio that they've just started doing maybe some strength and conditioning coaches online, or they've done some extra career training, and they're still trying to do it all. And some people can do it, but often takes, a good decade or more of your own clinical practice to probably get better at that art and science of it all. But in the short term, I think I think it's not being, what's the word I'm looking for? It's just, I guess, letting your ego step aside so you can work together with someone. I think there's a little bit of egotism sort of creep in some places, where it's like, well, I can do everything, so I don't need to work with this person or this person. So I think you just need to let that ego get by the wayside. All right, we better get into a bit of the nitty gritty stuff. Is so what, in terms of, we talked about that early phase part of ACL rehab, particularly the muscle inhibition effect, after injury, after surgery. What are your kind of, I guess, key rehab tips there for clinicians? Are you a big proponent of muscle stim, cryotherapy, isometrics? What's your kind of bag full of tricks look like?
Yes, and yes, right? I mean, that's what I do. I think the big thing is, early stim, actually patellar mobility, get their extension back, even a little hyperextension, make sure it's not symmetrical to the other side right away, but eventually they'll get symmetrical. But if they can't fire their quad and the patella is tight, the quad, they're not going to be able to fire their quad. So we got to make sure the patella can move. We got to make sure they can get into that, screw home mechanism, that end range extension, as close, somewhat. There's some conversations we could have on that. But then, it's NMES, it's cryotherapy to the knee joint. Some people talk about full body vibration. Or we don't have that, but maybe a little Theragun or hypervolt gun or whatever guns you have out there to stimulate the quad. Some people talked about there was one paper that talked about pulsed ultrasound, right? I think Grant Norton talked about that in a paper. So you're throwing everything at them because you hope something sticks, and so you want them to not look at their knee when they're doing their quad sets. You want to use external cueing so they can get their quad going and not have to focus on the visual input that some people will want to use because they can't really sense their knee in space or they can't get the quad to go. So you're trying to get them to activate that quad any way they can through quad sets early on, leg raises early on, and then eventually the gait training and all that. So I'm throwing everything at them at the beginning, and then blood flow restriction training as well.
Yeah.
So we're hitting it all.
Yeah, 100%. Well, that's interesting you say that, because I've just really started being particular with my patients when they're training, both in the early stages and middle stages, is not looking down at their knee. Even like a simple squat activity, even a lunge. Early on we're kind of trying to sort of get their technique right and sort of using some cues. But once they've sort of got the knack of it, it's like you're taking those things away from them and then asking them to perform the same thing. And just that simple action of just keeping their eyes up, all of a sudden now it just freaks them out. I've seen so many sort of, freaked out faces when it's like, well, I need to jump now, like with my eyes off the box I'm about to land on. It's like, yes, that's what you need to do.
Exactly.
So when you're playing basketball in a few months' time, you're not going to be looking down where you're looking. You're going to be looking up, chasing that rebound or seeing that defender in front of you. So you got to start thinking about this stuff now. So it's a game changer.
I've become less picky in cueing people and letting them figure it out. If they're like drastically shifting to one side, then I'll give them cues or put something under their uninvolved foot. But I want them to kind of, figure things out. And we use Vald. Shout out to Vald. Forcedex, Australian company. They've been great to us and very helpful in my ACL rehab kind of thoughts to put people on the force plate so they can do a squat and do 10 reps and see that they're 25% shifted to their uninvolved side, and then they can make the adjustments on the fly and see what it feels like to be only 4% shifted to the uninvolved side. So little things like that I think all help, but they're expensive. So not everybody has that, but do what you can to get people to figure things out on their own. You know what I mean?
Well, that's right. That's a great tip there, is that if you've got the tech, be it Vald, your force plates, or even if you get the old bathroom scales out, analog bathroom scales out, you can still get some really low tech ways of doing it. But that squat example is perfect. The amount of people that you see squat down and they're clearly shifting, but they don't really pick up on it in the mirror. To put something a little bit more objective under their feet is a really simple way. And if they can figure out a way to do it, that's even better. So just these little tips can drive rehab better. You touched on BFR there for a bit. What's your kind of, are you a routine BFR use in the first few weeks, or is it kind of user dependent depending on how things are going?
Yeah, I tend to throw it in there and see how people do. I use it, but I don't. It's not in there the full time. It's not. I wait 2 weeks until wounds are closed. Think the knee calms down. That's kind of my deal. I know some people do it earlier than that. I tend to wait 2 weeks. I do NMES for those first 2 weeks. I'll even superimpose NMES with BFR sometimes. But otherwise, if they have a good quad, I'll take the NMES out and do BFR. And that's it for a few weeks. Maybe I'll finish a night or a day with them with some BFR knee extensions to kind of get that muscle pump at the end, or BFR on a bike, something like that for some cardio and really gas them. But I really want to load them. Once I can load them, I want to load them with weights. But those first, like I said, those first 3, 4, 5, 6 weeks where they can't really do much, I'm using BFR. It slowly drips its way out, and then it's just kind of load them as much as I can.
Yeah. And do you use a particular unit, like a Delphi unit or a cuff, Vold cuffs. They've got the Vold team.
Yeah,
Have got
we have Vold cuffs. The air bands, is that what
yep.
they are?
Yeah.
I think they aren't with Vold anymore, but I could be making that up.
Yes. Yep.
Right. We have Suji, which we like. We have Smart Cuffs, which we like, and it's
Yep.
just like we have so many patients. We have 9 PTs in our company, so
Yep.
it's whatever's available at the time.
Yes.
I feel like sometimes, but they all work really well.
Yep.
I know some people use Delphi and all that. I think whatever you can
Yep.
fit into your budget.
Yep.
And whatever you value, I think is critical. So yeah, but I think there's something to it. I like it. I'm just don't use it for months and months and months.
Yeah, I agree, and I think that's probably keeping with consistent evidence about once the person can load, their knee is tolerant and they can handle those 60-70% 1 RM loads, and the patellofemoral joints okay, knee joints fine, swelling's okay, that there's actually no added benefit of just having it on. But in those early stages, there's the right patient, they get everything into it. And do you stick to around about the 80% occlusion mark, or are you lower than that?
I start them at like 60% to make sure that they can handle it. It's a new feeling for most people, and so God forbid you have somebody pass out doing it, which it may have happened, a few times in our facility. So like you want them to be comfortable with it, and then I'll slowly ramp them up to about 70 or 80%. And as long as they can handle that and they feel good doing it. Yeah. It's not fun for them though.
No,
and we do the typical 30, 15, 15, 15 that seems to be out there and accepted in the research, so to speak. So yeah, that's what we do.
Yeah, and a couple of exposures a week, 2-3 exposures a week on the knee extensions, leg press.
Yep. Yeah, exactly.
Awesome.
Yeah, we see most people 2 or 3 times a week. And just always monitoring anterior knee pain. That's my number one thing, is that if I'm overload them, every visit they come in, I'm looking at their knee extension, I'm palpating the patella tendon, I'm palpating the joint line, how's their knee now compared to the other when they came in the other day. And then I look at it pre and post treatment. I look at their knee at the beginning. I look at their knee at the end of treatment. What's changed? Is swelling better? Is it worse? It's usually better with exercise. And just making sure I haven't caused anything new to the knee that may be detrimental for future sessions.
No, that's cool. And just touching then on I assume graft harvest site, would you largely see patella tendons in your facility, quad tendons in your facility? What's the breakdown, would you say?
Yeah, if anybody follows me on social media, you probably know my bias, especially if you're on Twitter. But I'm a big patella tendon guy. I know there's been a shift to quad tendon. We don't get a lot of hamstrings anymore. I don't know if I know Europe does a lot of hamstring grafts, but I don't know if doctors are shifting away from that, especially with this new quad tendon. Quad tendon's been around for a while. It's just, it seems to be rejuvenated the past 5 or 10 years. But for me, patella tendon is what I grew up in, so to speak, as a PT. It's my feel good. I know it. I know how to handle it. Quad tendon grafts for me have been somewhat of a struggle, and I don't know if it's me and it's a learning curve for me, but I cannot get their quads to come back as quickly as a patella tendon graft. And the incision's tiny, so you're like, oh, and it's a super patella area. It's not kneeling pain. Everybody's like, I want a quad tendon graft. I'm like, well, you add 3 months to your rehab. I feel like, because it's just not. It's not as predictable in my hands as a patella tendon graft.
It is funny. In my experience of, I feel the same way about quad tendons. I don't know, probably managed maybe 10 to 20 over the last few years. But they're slow. They're slow to bend. They don't usually love bending beyond 90 degrees for at least 3 or 4 weeks. They just get a bit irritable. That harvest site, they take forever to get their quad strength back. Not that patella tendons don't take a while compared to hamstrings, but they just take that lot longer time frame. They're just a bit harder to work with. And I think at the end, if you look at re-injury rates, they're not that far superior, and they're not at all superior compared to patella tendons and hamstrings. So I'm with you. I've rediscovered the joys of patella tendons since relocating. So 3 years ago, we moved back to where I actually did my physio training up here, and one of the orthopedic surgeons up here, really experienced surgeon. He does primary patella tendon harvest, and I love them.
Yeah.
Working
I agree.
yeah, working in Melbourne. Melbourne was very hamstring driven,
Mhm.
most of the hamstrings. But what I grew to love, I think, like if you're going to sacrifice one part, the knee is going to get muscle inhibition. The quads are going to waste anyway. So kind of just double down on that area. Don't make the hamstrings really weak either. If you can
Right.
sacrifice, so, with a hamstring graft, you got the weak as hell quads and you got the weak as hell hamstrings. And that is a huge fight. That's,
Completely agree.
yeah.
Yeah, I completely agree. But patella tendons, to me, like I said, the most predictable. The surgeons argue, kneeling pain doesn't exist with with quad tendon graft,
Mm,
and cosmetically it looks better, and that's their selling point. And it's a big, robust graft, and I'm like, but I got to spend the
yeah,
next 9 months with them. You know what I mean?
yeah,
Like,
yeah,
listen to me too as well.
yep, yep,
I'm always selling patella tendon graft, but
yeah.
that's me. But yeah.
Yeah, and I think maybe and you having worked a hell of a lot more with them in the last, decade or more. Or I think, early on in my career, I was a bit afraid of them because of I guess the documented, you pick up any clinical sports medicine textbook, it's like these person's going to have anterior knee pain for life and that kind of stuff.
Right.
And yeah, I haven't seen that after working with a lot more of them lately. Like,
Completely agree.
yeah,
I think in the hands of some clinicians, it's going to exist. But I
yeah,
think in the hands of it's like if you go to a surgeon who does 10 ACLs a year versus a surgeon who does 200 ACLs a year,
mm,
the outcome's going to be different. If you have a PT that does a lot of rehab of a particular graft because they work with certain surgeons, the outcomes are going to be a little bit better. We learn on the fly. We figure things out, and most people we're going to apply those principles to, and they're going to do well. And so, I don't know. Again, it's surgeon dependent and PT dependent, but
yeah.
I don't know. I just again, it's predictable.
Yeah, and what's your kind of go-to early on? So, like my thinking now is I manage it like a tendinopathy. So in the first 4 to
Yeah,
6 weeks, I'm largely hitting it isometrically just to calm things down, get some muscle, get that quad to turn on, get some activation, just settle down that anterior knee pain and try and keep that low. And then we kind of build it up over the next 3, 4, 6 months as per a tendinopathy protocol. Is that a similar kind of approach that you guys take?
absolutely. We do the leg raises, we do isometrics, we do some early mini squats. But I think again, the big thing is get that slight hyperextension. Look at
Mm,
what their other side is. Make sure they can engage the quad and the knee and get that slight hyperextension, and make sure their patella moves well. Those are
mm,
I can't say it enough that those are critical aspects to be able to get the quads to eventually wake up and slowly load it. Because if you can get all those arthrokinematics to occur in the knee joint, when you are loading the quad, you're not going to be loading it at a slightly different angle than what it's intended for that person. Meaning their
yep,
gait's not going to be different. They're going to be able to get that terminal knee extension that they need and feel, and their knee's just going to feel better overall. And so I think if you can get all the basics early on, and you do basic strength and conditioning principles of slowly overloading them through isometrics and some early isotonics,
yep,
I don't see the issues that that has been discussed
yep,
numerous times in the research of the anterior knee. But yeah, kneeling pain, I get it for the first
yep,
6 months or
yeah,
so. Kneeling pain, of course, it's going to hurt. But I got somebody right now. She tries to nail on it more and more, and she's desensitized the area. Now she's fine.
yeah,
So
yeah,
I think it's just a desensitization thing,
yep,
and I
yeah,
think it's still tissue healing that has to occur.
yeah, yeah, absolutely.
Yeah,
The that's I just lost my train of thought. I had something really cool there. The patella tendons, I've just had a much greater success lately with them. Do you think knee extensions have got something to do with maybe your success with them? Like, 'cause I know once again you guys and your
yeah,
team are very pro having knee extensions and open chain work in your systems early.
yeah.
Like, because that's personally what I sort of feel like is been a big turnaround for me in my clinical practice, is making sure that open chain work, even with those patella tendon harvests that historically we probably wouldn't go too crazy with early, but isometrically on a knee extension machine, I'm going at them, reasonably
Yeah.
early. but then I make sure the inclusion of the knee extensions are in the program. Where do you currently sit with knee extensions post-op?
Yeah, probably similar. You know, I'm up on the literature, and I've always had there's not a lot out there. You know, you have your typical Benyon studies and all that show like a 4% strain on the ACL, and there wasn't anything that was overwhelming that said knee extensions were bad. I think it was just one of those accepted philosophies that were passed down generation to generation of physios or PTs that like knee extensions were bad from you know some you know early research or limited research, and it was just I think it was a time that it happened, and now we've kind of progressed through that, and you know, it was Florin Fiorelli, was out of Italy, has really good papers on that, on showing that you know quads come back easier, and there's no increase in laxity in the knee. So we have newer research that shows it's safe to do it. So yeah, I do it early. Multi-angle isometrics, even some active, either I start off 90-40 early on just to kind of get them going. And then by a few weeks out of surgery, I'm doing full active knee extensions, you know, like 4 weeks out, I'm doing full. I'm not loading them heavy, but they have an ankle weight on. Maybe they're doing BFR. So I can get that, you know, I can get that effect, but not have to load them heavy. Let the graft kind of incorporate 6 weeks, 8 weeks out. And then, I'm loading them. I'm not waiting 3-4 months to do that anymore. So I think that has helped. And then just doing everything else that we add on top of that. I think if you look at the research, a mini squat puts the same amount of stress on the ACL as open chain knee extensions. You know, Benyon showed that in like the late 90s, whatever it was. So, you know, we do mini squats. You know, I know that was that one paper that came out that showed that that walking had a 13% strain on the ACL. I don't know. 13% strain on the ACL is a lot of strain on an ACL. It's a lot of strain. If those MRI studies are, you know, comparable to other studies that have come out. So I don't know. I think we over try to simplify things, and we try to become too conservative. And don't even get me started about meniscus repair, rehab, and how we've locked that down for some reason still when we know we don't have to. So I think I get it. We need to be conservative. We don't want to be the reason why something happens to the patient's knee. But I think we could probably do a little bit more than what we're doing once the knee calms down, and we can respect biology to occur. You know, let the biology happen.
Yeah, agree. And the great tips and points there that, you know, those that haven't come across any of the open chain studies, because it did go quiet there for like a decade. Like we had, you know, the 90s, early 2000s. There was a paper, I think 2013 by Fukuda. That was kind of the last of the open chain exercise papers there for about 20 years.
Right.
And it was all a bit of a mixed bag, and everyone was a bit fearful still. And then all of a sudden, you know, it went quiet for over a decade. And now Fiorelli's, you know, pumped out a couple of papers again. And Lynn Snyder-Mackler and Brian Norrin did a nice opinion piece. And Kevin Wilk also did about the same time as well. So it kind of started to regenerate this conversation again, which is nice. And squats, walking, all just as straining on the ACL as what an open chain knee extensions are. So I think that's the perspective I think we all need, is that, you know, in everyday life, the ACL will be strained in many movements. So sitting on the edge of the bed, or sitting on a knee extension machine, or sitting on the edge of the bed with a very light ankle weight cuff is not going to make your knee explode like some people may experience it. Do you have any tips about, you know, some early career clinicians who kind of come across, you know, like a surgeon's protocol that says no knee extensions forever, or at least no extensions in the first 3 to 6 months, or at best? Do you have any kind of, you know, experience in navigating that space? Because I never do. I still can't to this very day. I just say, I'll just do it because I'm old and cranky, and I'll just do it anyway. But I'm sure there's a better way to handle that conversation with a surgeon who's saying that no knee extensions are allowed.
That's a tricky one. You know, the surgeons, I'm not, how do I even say this? Surgeons don't want to be told what their rehab protocol needs to be. So you have to be careful how you work. You can't be that nerdy PT that shows up and like, I got a research article right here that shows that. They don't want to hear that. But if you talk to them in the back of a meeting, you know, you go to a conference, you're like, hey, so-and-so, you know, it's a local conference in your town, or maybe you go with a patient to their post-op visit. I've done that a few times, and that has been huge to just kind of get that casual, maybe the patient walks out of the room, they're done with the visit, and you just kind of, hey, great, great working with you. Here's my cell. Just want, and you kind of casually talk to them, not at them. And it's more of a casual environment. I know they're busy in their office, so you may not have a lot of time, but I think if you can somehow see them at a meeting or, somewhere in a more casual environment, and you kind of let them feel like they're in control, but you're dictating your thoughts and you're kind of wording it a good way, I think you can influence a surgeon or a doctor more than you think, but you have to do it the right way. And then otherwise, I know what I can do with my patient. So I'm going to do what I know I can do and what the research says. And I'm going to do it at this point in my career. New grad, I think maybe you need to, if you're trying to build confidence with a surgeon, you got to kind of trend a certain way or tread a certain way. But I think having open discussions is critical, but having them in a fun, controlled environment where you're not talking at them, I think is key for surgeons, because egos and their 20 years of experience, you're not going to overcome that. You're going to burn a bridge if you word it a bad way,
Yeah. No, great tips there, Lenny. Thank you. It's always a really hard one, but it is going to be a slow burn, regardless of which path you take. It's going to involve a lot of time and relationship building, a lot of conversations. And I think talking to a few people in this space about this very same question, it's the same response. Don't just start flooding their inbox with papers or start bashing on their door saying this is not evidence-based, but you will burn bridges and you will not gain that respect that you need or want. And we need to do it a much more longer journey. It's a long journey, this one, but it
is a longer journey. But give them good outcomes, whatever it is. Give them good outcomes, so they're going to want to keep sending you patients. Because if you send somebody back that looks amazing at 6 months, they're like, "Where are you doing rehab?" And they don't know what's going on in the rehab, but they're going to see the results. You know what I mean?
Yeah.
So give them good results.
Yep, they'll remember that for sure. Speaking of which, with the we sort of leaned into it a little bit early about 9 months and return to sport. Do you have any? And you obviously bought into the VOLD testing systems. Do you have any key metrics that you like to see ticked off? Obviously, there could be a big bucket list of things, and obviously different athletes, different sports, and different requirements. But are there kind of a handful of non-negotiable pass marks or tests that you employ with your athletes, regardless of sport, before you give them a big green tick to get back to some kind of competition?
I mean, we like I said, we use VOLD. We have the Dynamo, so we do inline pull isometric. We do isometrics at 90, and so that seems to be reliable. We don't have an isokinetic device at our facility, so we don't do anything like that. But we do a 90-degree isometric knee extension, isometric knee flexion test. They stop that about 3 months out of surgery to get some baseline. Actually, we start that prehab. We start that pre-surgery, where we're looking at the uninvolved side. If we do, fortunately, most of our surgeons send them prehab to us, so we do get the uninvolved side because of that Delaware paper that showed the significant differences in their strength if you look at prehab versus limb symmetry side to side at the time of testing. So I do prehab testing, and then we use the force decks, and so we have counter movement jumps. We do a double leg drop jump from 12 inches, and then we do single leg drop jumps further on down the road. We also do 12 inches as well. And I kind of put on Twitter recently what people are doing is it 12 inches for all. And it was a mixed bag, but it seems like most people do 12 inches for both. Some people said 6 inches, some people said 8 inches. And we're in inches in the US, so whatever that is in centimeters.
Yeah, it's about 30.
Okay, I think that's what, and I think that's what most of the research says anyway. And so we do that. And then we have a 1080 device that kind of measures horizontal type stuff. So we just got that a few months ago. So we're trying to build that into our programs as well, to look at, starting with the involved leg forward sprinting, starting with the uninvolved leg forward sprinting, and being able to measure forces that way, along with using that in numerous other fashions. So we're trying to figure out how we're going to incorporate that. We have timing lasers, so we can do a 5-10-5 or something of that nature to kind of look at them cutting on each of their legs and see if there's a time discrepancy in their ability to generate force. We have blaze pods. So all that stuff, it's like a big complex, testing that Champion has come up with, and we're still finalizing it, but we've done a really good job, in my opinion, of having a bunch of different things that our strength coaches do and our PTs do, and then chatting about that patient, because again, it's a team approach. So
Yeah.
long story short, we have a bunch that we do, and I think it's critical to have that, but you can be paralysis by analysis if you try to take too much. So we're trying to fine tune things as well, because you can get a lot of data points, but it needs to make sense. So I think at least a counter movement jump, knee extension, knee flexion testing, and then maybe some kind of drop jump, because of those research studies that show vertical forces are critical for quads. I've gotten away from hop tests. I don't know about you. I don't do as many horizontal hop tests anymore. It's more vertical stuff.
Yep. Agree. That's definitely my kind of career progression has sort of swung back to a really simple list of, same thing as you, quad, hamstring, isometric. Same thing. We've just got isometric dynamo set up. Do you find isometrically, say like your quad score, are you finding like say 3.4 for males or 3.0 for males on an isokinetic machine? Are you finding that your isometric Newton meters per kilogram is beyond that, like even 3.5 to 4s in some instances? But that's probably the thing that I'm sort of still navigating as to how does that isometric score compute to isokinetic score, and is there something, do we still need to do both? I still don't know if we still need to do both. I think that work's yet to come, but I do sleep well at night knowing that my athlete is sitting in front of me with a 3.5 Newton meter kilogram score with an isometric quad.
I've put this question on Twitter because I'm getting 4.2. I'm getting like
it's big
kids,
scores.
like soccer players that are crazy strong, especially males, pushing 1,000 newtons or something like that of force, and they weigh 180 pounds. And so I put most people said, you're going to get those people. 3 seems to be a minimum. There's a few papers that came out. Nikki Van Mellick, she's put some papers out that show kind of a minimum or a general strength number that you need to have for males and females in certain sports, which has been very helpful. 2.3, 2.4 for females, 3.0 for males, depending on the sport. And so I use that as a rough guideline. So if I have somebody who's 1.9 on their uninvolved side and 1.2 on their involved side, your LSI is this, but you also need to get stronger on both sides. Right. And so I use that as a reference too. So everybody's getting a Newton meters per kilogram torque score at that 90-degree position, and then I make decisions based on kind of normal numbers that I found in the literature.
No, it's good, sensible. And I'm like you with my hop testing. I've certainly stripped it down to mostly vertical these days. I'll occasionally do like a single leg hop for distance just to see how they break, and it's more of a subjective kind of thing, as opposed to, I'm not really that interested in their distance hopped, even though it's nice to see, and their symmetry. It's like, it's part of the puzzle, but I certainly lean into, and I probably weight things differently. So definitely quads, you have to hit quads, and single leg vertical, you have to be up here. Single leg drop and your reactive strength index scores, you have to be here. If your hamstrings and your single leg hop for distance and all these other measures are probably, they're okay, but they're not perfect. As long as these other ones up here are smashing it out of the park, then I feel pretty comfortable letting people go. So I used to have this big long list, and it's now shrunk over the years. So it's
I agree. And then of course it's my eyes. I'm watching them weight train. I'm watching them do some agility stuff in the clinic. I'm watching how their knee responds. I'm watching their face. Are they fearful of doing something, or are they excited to do something? How do they respond to it? There's that, there's that gray area. There's that, you can't kind of teach that. It's not the numbers. It's more, I want to look the athlete in the eye and tell them, all right, we're going to go do this. And are they like surprised, or are they like, let's go? Because they know they're ready. We haven't even talked about any any ACL RSI testing or anything like that, which I use a little, but I know my athletes lie. They always say they're ready to go. So, any kind of Tampa scales or any kind of fair scales, I don't use as much as maybe some do. I don't know if you do, but I feel like when I give them to high school, college kids, especially guys, they're like, my knee feels great. I'm ready to go. I'm just roll my eyes at them, like, come on, So, certain population I will and kind of track them, but it's more the watching them train and the objective numbers that I get from them.
Yeah, yeah, no, that's fair.
Yeah,
Very good, mate. What about so you certainly leaned into a couple of success stories you had. Can you think of any really bad ones you've had? And if you had your time, if you had your time again, what kind of things? Just more so for those early career clinicians who probably haven't experienced much failure yet. I talk about
yeah,
failure all the time on this
right,
podcast, and we all talk to experienced clinicians who had our big long list of failures. And really, the only way we
right,
get better is by learning from our mistakes. So, is there any
right,
you don't have to share names or share particular details, but any
right.
any bad outcomes that you can think of that come to mind?
No, Mick, I'm
No,
pretty perfect
perfect.
as a clinician. Yeah, I mean, I don't know what you
Fair
expect. No,
enough.
I mean, of course. Yeah, I mean, you got kid like a kid I mentioned earlier went back in 4 months. He survived. He did not re-tear it, but you never know. Or I can mean you just think of you never remember the successful stories. You just remember the re-tears. Like I had a high school
Yeah.
girl early in my career who re-tore. Sweetest girl. I was in Alabama, and like she came in and she retore it, and I was devastated because she worked so hard. And then she's like, "Well, they think I retore it because I wasn't wearing orthotics in my shoes, and she had flat feet." And I blame myself for missing her flat feet. I remember that
Oh
story.
man.
But I think if you give everything you can to the patient and you are careful in your testing and you load them appropriately and you've educated them from prehab till return to sport and they understand the risks, then I hope you've done your due diligence and everything you can to help that person get back. And ultimately, it's going to be up to them and their parents to make the decisions. I'm just there to kind of guide the ship and give them the information so they can make that ultimate decision that little Billy is ready to play high school soccer his junior year because he has to because he
Yeah.
needs videos to get to college. You know what I
Yeah.
mean? And we're only 6 months out. We need to make I need to see more. But if they have to, that's ultimately their decision, and I'll talk to the surgeon. But yeah, there's always going to be the tight knees that never get a cyclops lesion. How could I have been better in getting their motion back earlier? Or the tight knee into flexion. What did I do wrong? I struggle with hamstring grafts to get
Yep.
knee flexion back, in my opinion. And
Yep.
so I'm always trying to. Not that I see many of them anymore, but I always struggled, and I don't know why. The pain back there was always tremendous where they took the graft from. And
Yep.
so I'm always trying to reassess, like, where did I go wrong? Why did I, lose some flexion in their knee? And so, yeah, there's
Yep.
always those cases that you look back on and you learn from those, and hopefully the outcomes eventually, fix themselves. You're not affecting that person's life forever.
Mm.
But short term, man, it affects me.
Yeah.
Especially early in my career. You go home at night and you're like, what did I do
Yeah.
wrong?
Oh
How could I
yeah.
have been better? Yeah.
Yeah. Yeah.
Yep.
No, we've all been there. The second injuries always hurt, especially if you're
Oh, yeah.
especially like the ones that hurt the most, the ones because you've had a great relationship with them. You've
Yep.
worked with them over 12 months and they've returned back to you. Because some people you'll never see again. You won't know if they've
Right.
re-injured their knee again
Right.
or how successful it
Right.
was. But the ones that come back to you because they liked you, you were a good person. And I think that always kind of makes me feel comfortable in the end. Is that they're coming
Right.
back for their rehab again because they trusted me, obviously,
Right. Yeah.
to do the job the first time. So that's why they want to go
Yeah.
around again. So that there's no
Yeah.
blame associated with it,
Right.
especially if they're coming back to you. So they're the ones that always hurt when you have to look at them in the eye all the time. But if you
Yeah.
know you've done your job and you can sort of go back and go, yeah, I did everything right. And unfortunately, this
Right.
one just wasn't to be. Yeah,
Yeah.
but yeah,
Yeah.
they're never
I
easy.
never.
Yeah,
Right. But yeah, it's very nice when somebody comes back to you. That means they trust you and
yeah,
you connected with them. And so they trust your expertise. Yeah, definitely.
yeah, exactly right. Well, Len, you've been wonderful so far. Last question, mate, before you can
Yeah.
go toddle off, put your slippers on, and have a nice cup of tea before bed. Just some words of advice for the young clinicians who are watching and listening. Probably a two-pronged question. Just general physiotherapy advice. If you had one piece of advice to be a great physiotherapist, what would that be? And then from an ACL specific point of view,
Yeah.
what would those sort of two things be? Physio and then ACL. What hot tips can you
Yeah.
provide?
I think keep an open mind. More than you think, but you're not going to be confident early on. So getting reps is going to be critical.
Mm.
So I know a lot of early career professionals and young PTs. are looking for a mentorship and a slower kind of facility where they only have to treat 8 or 10 patients a day. I was the opposite. I got good mentorship, but I was treating 20 to 30 patients a day. So my volume of patients and my mental database of patient care grew exponentially faster than many. And so I had a lot of experience quickly early on. And I get it. That's busy for a lot of PTs, but man, it made me a good clinician, and staying on top of the research, and not being too egotistical. Like I want to work with my peers and talk to them. And I go to meetings and I talk with them in the back of the room, and I'm open-minded and connect and thank people and be respectful of people. I think all that stuff is critical. And that applies to ACLs too. It's the same thing. Like you're gonna, more than you think. You're not gonna be confident. So see the volume of patients that you can see, but have somebody that you can text, have a CI, a clinical instructor that you worked with. I have students text me all the time that all get my cell and all have access to me whenever they need me on either a DM on social media or my cell phone. And I want to help them because we're all in this together. So, see as many as you can, talk to doctors, go to doctors' meetings. I mean, my God, hearing doctors speak on ACL and what the surgeries are involved and influencing how the rehab is, and then you can influence the rehab that they are going to prescribe to their patients. It's having that team approach with a good surgeon, which I fortunately have in Boston with Dr. Peter Asnes and Dr. Arun Ramappa at 2 different major hospitals here in Boston, is critical. I can text them whenever I need to and get information. So get good relationship with your peers, with PTs and doctors. And it's just going to make your life so much easier. And then reach out to people like you and I who been doing this for a while. We're here to help. That's why we do these educational sessions. I want clinicians to be better. I learn from you guys, and I'm selfish, so I have to keep up with the research, or else I'm going to be cast aside.
That's it.
I don't want to be that person. I'm still relatively young. I need to stay on top of things. So keep an open mind and keep building your volume of patient, databases in your head. And I think that's a critical key for a young clinician. Yeah.
I love that message. I love how, like it applies not just to ACLs, but, be that a good, open-minded, thoughtful, really curious clinician. Just, it doesn't matter which limb or which body part you have an interest in, or you end up specializing in at some point in your career. But, at all that cornerstone to being a good clinician is being that curious, open-minded, conversational, being open. They're just like really good features of being a good human being. So just be a good human being.
The PTs that I interact with, the PTs that I interact with at meetings they are still like that. The Kevin Wilkes are still pushing things forward and influencing stuff and asking questions and talking to their fellow PTs. And it's great to see. And that's how I was brought up, and that's how I'm going to continue to be. And social media has been great to even expand upon that. And then Zoom calls like this and podcasts is another medium to learn. And so take it all in. But, just don't overwhelm yourself. Just kind of, we're here for you if you have questions. So, look me up on social media, and I will do my best to answer, anything you got.
Very good. Well, Lenny, thank you very much, mate. Well, that's you've been wonderful. Always a wealth of information, and always wonderful chats when we get together, mate. So I appreciate your time tonight. So thanks for being here.
Yeah, thank you, Mick. If anybody has anything, you can find me at Twitter, X, whatever we're called now, at LenMacPT, LenMacPT, or on Instagram. My website is poopy right now, so I'm trying to rebuild that. But definitely on social media, find me. If you have any questions, I'll do my best to answer and chat. And I'm always putting content out like you and trying to push things forward. Yeah. Perfect. Thanks, mate. And if you got any questions, if you can't find Len for whatever reason on social media, just email me directly. Everyone's got my email, mickwhughes@gmail.com, and I'll pass on the questions to Lenny. Thanks everyone for listening and tuning into this one. Stay tuned for the next one. Next episode coming out soon in a few weeks' time. So until then, bye for now.